Good afternoon. Sorry, Camilla. Good afternoon, everyone, and welcome. I'd like to thank you for attending this Endo-ERN webinar. My name's Amy Casey, and we're really excited to get started with this presentation. This webinar has been organized by Endo-ERN members of the consortium of the Helsinki University Hospital. The topic area falls under Endo-ERN's main thematic groups. Number 1, adrenal, and number 2, calcium and phosphate homeostasis. And I want to thank the MTG1 and 2 chairs for supporting this event. Of course, we would like to thank Professor Lionakis for making time in his very busy schedule to give this presentation to our members. Before I hand you over for introduction, I'd like to just go through some small housekeeping. We will take questions at the end of the presentation, and you can type them in the question box that's in your control panel. Or if you prefer, you can raise your hand and I can unmute you and you can ask your question directly. Just to let you know that this session is being recorded and you'll receive a recording within 48 hours if you would like to share it with your colleagues. Now, without further ado, I'd like to hand over to you, Professor.
Good afternoon, everyone. Just a short welcome from me as well. I'm Camilla Lionakis. I'm the Chief Endocrinologist here at the Helsinki University Hospital. We have quite a few patients with APS1, and I'm thrilled and excited that we can have this webinar today. And now I will hand over to Mikko Seppänen, who works here at the Helsinki University Hospital. He is the chief of all the rare, the ERN consortiums here at the Helsinki University Hospital, and my old colleague. So Mikko is the chair, and then Michail is the professor who will then continue. Thank you so much.
Thank you, Camilla, for your kind words. I just want to welcome all to this session where Michalis, my longtime friend, will present his work of over 10 years that will really make a difference to our patients. I myself am not an endocrinologist, I'm a clinical immunologist, and I'm the ERN-RETA HCP representative here in Helsinki. But what you really want to hear is Michalis and his groundbreaking results, and I will hand this over to Michalis now.
Well, thank you both for the kind introduction and for allowing me to present some of our work over the last decade. So I'm an infectious disease and immunology trained physician scientist, and I work at the National Institutes of Health at NIH. And what I'll try to do over the next about 40 minutes is share with you an about 11-year now journey that we've had with patients with APECED, a disease that I knew not much about before 2012 when I started my own lab. But as I'll show you through a prospective evaluation of about 200 patients now and corroborating basic research, we've been able to learn a lot about fundamental immunology, but at the same time have had the humbling experience to develop mechanism-based treatments that, as you'll see, have so far helped a growing number of patients with this devastating autoimmune disease. So I'll start with a vignette of a patient that we saw here who at 3 months of age developed a red pink urticarial eruption that really went on and off until the age of 3 and then went away and never came back. At 6 months, he had oral thrush. And then starting at year 1, she had multiple, what at the time were thought to be pulmonary infections. As you'll see later, eventually she was diagnosed 5 years later with bronchiectasis, so structural lung disease already at the age of 6. And then during her second year of life, she developed 4 different autoimmune manifestations listed here, gastritis, hepatitis, enamel, and nail issues. At age 4, she developed a seizure due to low calcium. An astute endocrinologist who put together the fact that she had hypoparathyroidism and Candida, as I mentioned earlier, thought of APECED, eventually led to the suspicion of and diagnosis of the disease, but at the age of 5. We saw her several years ago now at age 9, and she came to us because she had worsening cough and dyspnea on exertion, so she wasn't actually able to walk without feeling short of breath. This is how her imaging looks like. So she had severe ground glass opacities. She had already developed bronchiectasis, as you can see here. She had desaturation on a 6-minute walk and abnormal pulmonary function tests. So to summarize here, past medical history, which clearly indicates that she had what's known a classic dyad among the classic triad manifestations of chronic mucocutaneous candidiasis, adrenal insufficiency, and hypoparathyroidism. So she had 2 of those. But you can also appreciate multiple other diseases that happen interspersed in between those lost opportunities, if you will, of making an early diagnosis or even suspecting the diagnosis of APECED before, again, an endocrinologist who was savvy to the diagnosis thought of it and made the diagnosis. So APS1 or APECED is a rare, mostly autosomal recessive syndrome that's caused by mutations in the autoimmune regulator gene. I got very interested in this, being an immunologist who is very interested in host defense against fungi, primarily and initially because of the signature infection that these patients develop, chronic mucocutaneous candidiasis, or CMC. About 85% of them develop this infection. And also, obviously, as many of you know, this is a multi-organ autoimmunity, autoimmune syndrome, and described fundamentally in Finland, where a lot of great work has been done through the decades, and the diagnostic criteria of, again, as I mentioned earlier, having 2 out of 3 of the classic triad of hypoparathyroidism, adrenal insufficiency, and chronic mucocutaneous candidiasis is really a very characteristic triad for this syndrome. As you can appreciate, the summary of the early reports from Scandinavian and European countries highlighted that this is primarily an endocrinopathy, multi-organ endocrinopathy with some non-endocrine manifestations, as you can appreciate here. Now, fundamentally, AIRE is very critically important for central immune tolerance, and APECED is a prototypic disease where central immune tolerance fails. The reason for that is AIRE is important for expression of tissue-specific antigens in a specialized subset of thymic epithelial cells called medullary thymic epithelial cells, or MTECs. And it's actually very important for the expression of these self-antigens that leads to the negative selection of the self-reactive T cells that we all generate. But because of AIRE and that expression, they're purged and they don't leave the thymus. In these patients, that AIRE's function is missing, these tissue-specific antigens are not expressed on MTECs. As a result of that, autoreactive T cells escape in the periphery, and they've been shown in mouse studies to be both necessary and sufficient to drive the autoimmunity phenotype. And what you see in these patients and in mice is significant amounts of lymphocytic infiltration by self-reactive T cells that cause tissue injury and eventually organ failure. So I work here at the NIH Clinical Center. This is about a 250-bed research hospital. And the close proximity of the hospital with our labs enables the possibility to cross-fertilize basic and clinical research. And what I hope to do on my talk today to show you an example of how we took advantage of this unique environment to understand better how this disease is mediated and, as you see, develop treatments for them. Now, when I started, I made a decision to not focus on what my primary interest was, which was perhaps candidiasis, but rather mobilize and assemble a trans-NIH group of collaborators with the idea that this is a multi-system disease, and if we understand all facets of the syndrome, we might be able to not only understand why Candida develops, but also help the patient. So I assembled a team of physicians and physician scientists that you see here, spanning 10 different NIH institutes, where the idea is the same endocrinologist, the same hepatologist, and so forth will see all of the patients. This is my own lab team members, past and present, and incomplete list actually of basic and clinical investigators that have focused on what I'll show you today. And what the idea has been through since the beginning was that the patients will come at NIH. All of the workup here is free for the patients, is covered by the NIH, and everybody would undergo a very similar clinical and research evaluation. So they will be seen by the same physicians that I showed you from the specialties that I mentioned, whether they had or they didn't have the corresponding autoimmune manifestation. We thought that was very important. So we tried to understand what's normal for lungs or GI disease within this context of the disease, not with healthy volunteers. Everybody gets a whole genome sequencing, not only because to verify the AIRE diagnosis, but for future development of knowledge with regards to potential other gene modifiers, as well as a uniform laboratory and imaging workup and procedures that are tailored to their clinical manifestations, but through our IRB approved protocol, also used for research. So we've seen over 200 patients now in the last 11 years. I recall when I was interviewing for my tenure track appointment that they were asking me whether I'm going to go to Finland to see these patients. I think the idea back then, and the consensus was that there is not much of APECED in the United States. We made an effort to calculate an approximate prevalence of the disease in these countries. You can appreciate that there are probably a few thousands of these patients in the United States that now we start seeing in larger numbers compared to when we started. So what I'll try to do during my talk is really hit on three separate issues that really interconnect with each other, starting by our initial clinical phenotyping and what we were able to observe. So as the patients were coming and we were evaluating them in this comprehensive manner, what was very clear was that in addition, obviously, to the classic triad and the endocrinopathies that were very well described, and we also saw, is that the spectrum of the disease was far broader than perhaps initially or broadly recognized. So we've seen over 35 disease manifestations in our patients so far, and particularly this hexad of enteritis, hepatitis, gastritis, pneumonitis, a skin rash we'll talk a little bit more about in a minute, and Sjogren's was pretty prevalent in our cohort. So we use this detailed clinical phenotyping to uncover that what we now call an adjunct triad of these urticarial eruption that we now call APECED rash, enteritis that causes intestinal dysfunction, and enamel hypoplasia, as you can appreciate, happens with the same frequency and time frames with the classic triad. And we proposed at the time an expanded diagnostic criteria that would take into account both these triads. And by developing any two manifestations within this hexad, if you will, in this first data set that has now been validated in additional data set to include European patients, the diagnosis could be accelerated by half. So in this particular data set, by 4 years. The implications of that would be that about half of the patients could have been diagnosed earlier before actually presenting in the ER with life-threatening endocrine complications. So as I mentioned, we've now validated those criteria. This has helped actually raise awareness that it's not going to be only endocrinologists that will see these patients. So we've now have seen over the course of time in our country here in the United States, referrals from dermatologists or gastroenterologists or pediatric dentists. We're pleased to see that, but it also raises another very important point, which is, as you'll see during the end of my talk, if we're now successful in treating well-established disease, it does raise the possibility that in the future, as we recognize these patients earlier, before developing irreversible manifestations and tissue injury, perhaps we could implement preventive strategies, and we've already started that, so I'll hit on that at the very end. Now, this is the youngest patient we've now diagnosed. This is an 8-month-old sister of a known APECED patient who at the age of 8 months developed this what we call APECED rash, which is really a neutrophilic dermatosis. In this particular case, it helped making the diagnosis and surveil her calcium and ACTH stim test so that she didn't develop symptomatic endocrinopathy failures. But as I mentioned, we're now moving towards implementing preventive treatments at that early stage as well. Now, the second part of my talk, what I would like to highlight is a disease that was actually not very well characterized when we started. Through, again, early experiences with some of the patients that had very severe autoimmune lung disease, including the patient that I described in my opening slides, that presented the challenge to us to try to understand how this manifestation might occur and how we might be able to treat it. Now, what the literature indicated before we got started is that this is a relatively uncommon manifestation. It was known that there were patients who developed bronchiectasis. There were 2 autoantibody targets that had been shown to correlate with the presence of pneumonitis in patients. It was known by an elegant study done in the mouse model by Mark Anderson that T cells that are specific for one of those autoantigens can actually directly transfer the disease. It was very evident from those case reports that this could be a life-threatening condition for which, however, there was no indication that what to do to treat. So in the spirit of the uniform prospective evaluation that I alluded to, all patients that come at NIH, they get the same evaluation, including a non-contrast low radiation chest CT, regardless if they have symptoms or not. And if they have symptoms or their CT has abnormalities, they all undergo a uniform appropriate pulmonary evaluation that includes microbiological, functional, and bronchoscopic evaluations. Turns out that in the over 200 patients we've seen now, 4 out of 10 of them actually have pneumonitis. Most of them have come to us with a diagnosis of asthma while they actually had autoimmune lung disease. And the way that this important manifestation presents is through an early phase of interstitial lung disease that looks like pneumocystis pneumonia, if you will. As you can see here, this is a girl who also came to us with chronic cough, which is the common presenting symptom in most of them. And again, she came to us with a diagnosis of asthma. This is another girl who also came to us with a diagnosis of allergic bronchitis. I think you will all agree that those diagnoses don't look like that in the CT. Then what happens when uncontrolled lung inflammation goes for a while unabated is that structural lung disease occurs, bronchiectasis. That's when we start seeing patients going from dry cough to producing thick secretions in the mornings. They get colonized with bacteria and they start having decreased DLCO, desaturation on 6-minute walk. These are a few examples of patients with now developed bronchiectasis. This is another individual. And then what happens, unfortunately, over the course of time, if this doesn't get recognized and treated properly, patients can get very severe structural lung disease. That's when they can actually present with secondary infections that you see in patients with bronchiectasis. About 20% of the patients can have require home oxygen, and they can have severe PFT abnormalities. So this is an example of 2 patients that we saw early within the first 15 patients that we saw at the NIH early in the course of our natural history protocol. This is a 14-year-old boy at the time who, as you can appreciate, had almost all of his lung parenchyma replaced by bronchiectatic lung with still evidence of inflammation. This is another picture. This boy started having cough at the age of 9. And we saw the patient here at NIH 2014 for the first time. So 5 years later, had already respiratory failure, was on home oxygen, and unfortunately died 6 months after we saw him. This is a gentleman who we saw at the age of 50 because he had developed non-tuberculous mycobacteria. This, at the time of when he was 7, as a boy, was taken to an allergist and had the labeled diagnosis of allergic bronchitis for almost 40 years before he developed bronchiectasis to the point that he had structural lung disease. So a disease that can vary in progression We see more often now the more rapid, young kid progression to end-stage lung disease as opposed to this gentleman. And that's the reason why chest CT we feel is absolutely important. About 10-15% of the patients can have radiographic abnormalities without persistent symptoms yet. And part of the reason I think where this entity has been underdiagnosed is because some of these autoantibodies that are highly specific, over 90-95%, they are not the most sensitive. So an absence of an autoantibody against KSNRG, for example, does not rule out pneumonitis. So as we were seeing these patients 7, 8, 9 years ago, we started a project to try to understand what the pathogenesis of the disease is. As you can see here in endobronchial biopsies, you see here the cilia, a thickened basal membrane, and a lot of T cells that are infiltrated the submucosal and intraepithelial areas, which is not normal. So we've done this in non-APECED healthy volunteers, and there shouldn't be T cells in our airways in that to that degree. And when we do transbronchial biopsies, you can see here already transbronchial thickening and the bronchial. So transbronchial biopsies on the thickened bronchi, you see the hallmark of the disease, which is an autoimmune bronchiolitis. And when we zoom in into a bronchiole, you see again the extensive T cell infiltration, both submucosally and intraepithelially. But what you also see here is B cells playing a major role. You didn't see that many B cells in the endobronchial space, but deeper in the tissue, you see these large B cell aggregates in the majority of the cases. So you have this profound B and T cell infiltration in the lung of these patients, which then led us to mouse studies where we can interrogate which of those cells matter most. And what you can see here is that in the mouse model, the mice develop a similar bronchiolitis and autoimmune lung disease. That actually leads to, it's a major reason for why they die from multi-organ autoimmunity. If we remove the T cells from these mice, we restore completely lung architecture. This is not surprising based on what we know about the pathogenesis of the syndrome. And if we remove mature B cells, we still get autoimmune lung disease, but less dramatic compared to mice that have mature B cells. Now, work in Diane Mathis' group had shown that B cells can actually act as antigen-presenting cells for T cell aggravation, and that's really the likely pathway by which these B cells aggravate T cells in the tissue. But this then led us to devise a protocol. We're talking about 2013, 2014 now, early days, and we took advantage of this data and of the fact that in CVID-associated interstitial lung disease, there was already literature that the combination of a T cell modulator like azathioprine or mycophenolate, together with rituximab that depletes B cells, can actually remit that disease. And because we knew that a lot of patients who were treated with azathioprine or mycophenolate in APECED for autoimmune hepatitis, they could tolerate it, so it was a safe modality. Number two, a lot of them in retrospect, they would come and tell us, my asthma went away when CellCept or azathioprine was started. We're able to find imaging studies, and they clearly had autoimmune lung disease. So we developed at the time a scheme by which we would take patients and give them either azathioprine or CellCept together with rituximab. And we published these first 5 consecutive patients by 5 years ago. We've now treated over 20 patients. The data for the remainder patients are the same. They had resolution of their clinical symptoms and almost complete resolution of abnormalities, with the exception, obviously, of bronchiectasis that is irreversible. So here's some examples. This is the girl that I presented the initial vignette, who had these radiographic ground glass and nodular opacities. This is a month after treatment, and this is 6 months after treatment. These are coronal views of the same to see the extent of the disease, how well it resolved. This is another patient as an example. This actually is, at the time, asymptomatic patient that is not chronic cough, who had already ground glass opacities, early bronchiectasis, also went into remission with improvement in their pulmonary function tests, in their not desaturating anymore on 6-minute walk. So at the time, we were able to control autoimmune lung disease, and the sooner you start therapy, obviously, is better, because bronchiectasis, when it gets to the point of being very severe, is very difficult to completely go back to restore. So we were very pleased with that. We're also very pleased that we were able to extend both the pathogenetic and treatment features of primary inherited AIRE deficiency to a syndrome that features secondary AIRE deficiency. So thymoma patients also develop a poorly defined interstitial lung disease that actually has exactly the same features of APECED-associated autoimmune pneumonitis. And not only it has the same features, but it, as of recent, we were able to treat now 4 patients with thymoma-associated interstitial lung disease, and they also respond to the same therapy. There are other more common polygenic autoimmune diseases, such as idiopathic Sjogren's, that appear to also have a similar pathogenesis of interstitial lung disease with autoimmune bronchiolitis. That's an area where we want to also expand. So despite, though, this success, what was also very evident was that while we were able to control autoimmune lung disease and also autoimmune liver disease, azathioprine and CellCept are well-known modalities that are used to treat autoimmune hepatitis outside of APECED, the rest of the syndrome would not respond to these treatment modalities. So their candidiasis wouldn't get better, their dermatological manifestations from nail dystrophy to alopecia to vitiligo would not improve. There are severe GI manifestations from enteritis to gastritis or colitis in a few patients, and other features, that is, of the disease, would not respond to the combination of azathioprine and rituximab. So although we were happy with the successes we had for some of the disease manifestations, we're not happy with the fact that we couldn't put patients in complete remission. So over the course of years, we obviously were very interested in understanding what might be the effectors by which these T cells that are self-reactive and are both necessary and sufficient to cause tissue injury in this syndrome. What might be the mediators by which they exert those detrimental effects? So we took an agnostic approach, and we asked a very simple question: what are these T cells making? What's their polarization in tissues that are affected by autoimmunity? And what you can appreciate here, using flow cytometry in the lungs, salivary glands, and pancreas, that CD4 T cells in the AIRE knockout mice make a tremendous amount of interferon gamma. The same thing applies for CD8 T cells that I'm not showing here for the interest of time. And that polarization to making a lot of interferon gamma is specific because they otherwise make normal levels of IL-17, IL-22, IL-4, and IL-10. That is other prototypic cytokines made by T cells. These reflected into increased levels of interferon gamma, both in the serum and in multiple organs affected by autoimmunity in these mice. And in a way, was an extension of a prior paper we had 3 years ago, that showed that in the oral mucosa of the mice, where oral candidiasis develops, there is also a profound increase in interferon gamma production by CD4 and CD8 T cells, and interferon gamma excess in the total tissue. Now, if we look at how interferon gamma signals, it binds to its receptor complex of interferon gamma receptor 1 and 2, activates JAK1 and 2. That leads to phosphorylation of STAT1. Downstream of that, you get an induction of interferon-stimulated genes. A classic one for interferon gamma and selective for interferon gamma is CXCL9, which is a chemokine that recruits interferon gamma producing T cells into tissues. So we didn't only look at interferon gamma, but then we looked at all of the readouts downstream. And what you can appreciate in the upper panel, these are Western blots of phosphorylated STAT1 as a surrogate of enhanced interferon gamma responses. You see impressive increases across all tissues. And downstream of interferon gamma and phosphorylated STAT1, you see increases in CXCL9 in all tissues and in serum. And these increases are interferon gamma driven, because if we eliminate interferon gamma from AIRE knockout mice, that increase goes away. Now, we went to show this in 8 different tissues, endocrine and non-endocrine, affected by autoimmunity in mice, as well as in rats, a rat model that was developed in France. It appeared that in preclinical models of AIRE deficiency, this pathway was significantly turned on. Now, back in 2021, we had published that when we genetically delete interferon gamma from AIRE knockout mice in the oral mucosa, that makes a huge difference in them not developing oral candidiasis. So you can see here an AIRE knockout mouse having these filaments from candida in the oral mucosa. If you genetically ablate interferon gamma, that goes away. We can do that with 2 FDA-approved modalities, a monoclonal antibody against interferon gamma and a JAK-STAT inhibitor, ruxolitinib. So in the oral mucosa, that matters for candida susceptibility, and the reason why that happens is because excess interferon gamma activates phospho-STAT1 on epithelial cells that leads to an impaired epithelial barrier by impairing epithelial cell survival, permeability, and proliferation. That allows candida, which is otherwise a colonizer, to invade and cause disease in the setting of a diseased, disrupted epithelial barrier. So while we knew that about candida, we obviously asked the question, does this also apply? That is, if we genetically ablate interferon gamma, does that make a difference in all other autoimmune manifestations of AIRE deficiency? And the answer was yes. So you see here impressive autoimmune lung disease, Sjogren's syndrome, exocrine pancreatic insufficiency in the AIRE knockout setting. AIRE gamma double knockout mice have no inflammation. And when we look at immunohistochemical stains for CD3, so you see all of these impressive T-cell infiltration in the lung and salivary gland and in other organs I'm not showing you here for the interest of time. And you eliminate interferon gamma, you lose that infiltration of these self-reactive T-cells in the tissue. Now, going back to the schematic, at the time, we're now, several years ago, there was not yet an FDA approval for the interferon gamma monoclonal antibody emapalumab, but there were JAK1, JAK2 inhibitors that were already FDA approved. So we decided to ask the question whether JAK1/2 inhibition with ruxolitinib, which was already FDA approved since 2011, might have a similar effect, because this could potentially open up a window to translate that data to humans. So when we took AIRE knockout mice and we gave them ruxolitinib, all of these phospho-STAT1 and CXCL9 signals were decreased to wild-type levels. And interestingly, also upstream of JAK-STAT, these effects lead to a decreased production of interferon gamma by T cells, both CD8 and CD4. So ruxolitinib restores the entire axis, if you will, from interferon gamma production to phosphorylation of STAT1 to downstream targets to wild-type levels in AIRE knockout mice. And that does have an effect to autoimmunity. So again, you see lung, salivary glands. We've looked at several other organs. There's restoration of histology to wild-type levels. And again, an absence of autoreactive T-cell infiltration into the tissues. And if you leave AIRE knockout mice in the node background untreated, the same way that would happen in humans if we were living in 1600s and we didn't have medications, these mice succumb to the infection, to the multi-organ autoimmunity. And with ruxolitinib, they live, we've aged them to, I think, 40, 50 weeks, and they are all happy, and their autoimmunity is still not present at that far later. So we're not delaying the development of autoimmunity. We're actually abrogating its manifestation. Interestingly also, as I alluded to earlier, but now expanded with also treatment data, if we pre-treat mice with ruxolitinib and then come with a candida infection, the restoration of the epithelial barrier doesn't allow for candida to cause disease, but we can also come now and first infect with candida and then start ruxolitinib without any antifungal therapy. That actually leads to improvement of candidiasis. That is, treating these mice with an immunosuppressant can actually help treat infection, which is a bit of a counterintuitive statement when it comes to infectious disease, but again highlights how in this particular setting, if you will, T-cell driven autoimmunity appears to be a big part of why this disease causes candidiasis. Now, these are all mice. Mice are important because they can help us drill down into the mechanisms, but humans are far from being as simple as mice are. So the obvious question that arose is that pathway and the treatment response applicable to patients with APS1. And one of the first pieces of data we had for a few years now was an unbiased proteomic screen in the serum of these patients. And what you can appreciate here, this is a heat map that shows the genes that are increased in the serum of patients versus healthy controls. You see CXCL9, again, the interferon gamma inducible chemokine being at the top. And when we feed this through a GSCA analysis, interferon gamma response was the most upregulated specific pathway in the serum of these patients. Now, we then went and developed in situ tools to interrogate the pathway in human tissues. This was both with immunohistochemical and in situ hybridization methodologies. So you see here as an example, a stomach on the left of a patient with gastritis and the lung on the right of a girl with autoimmune pneumonitis. You see on H&E in significant amount of inflammation, impressive signals for interferon gamma, phospho-STAT1 and CXCL9. We've actually done these biopsies in the GI tracts of healthy donors as research, and all of that brown is not normal. That is, in the absence of AIRE deficiency, there is no interferon gamma in our mucosal surfaces. Now, we've gone to show this now in 12 different tissues affected by autoimmunity, from kidney to liver to salivary glands to the intestinal tract and so forth, in over 60 patients. This is an example of a patient's esophagus with, again, impressive phospho-STAT1 and CXCL9 levels. And in the tissues where we have access to biopsies, also in healthy donors, primarily oral, esophageal, and duodenal, where we've done unbiased RNA sequencing and corroborated also in mouse data, in those tissues, the interferon gamma excess is the top pathway that we find in these tissues in patients and in AIRE knockout mice. So all of this data then led to the question, well, if in mice we can ameliorate the multiorgan autoimmunity with a JAK inhibitor, and the mice and humans appear to have a similar excess of interferon gamma, can we have the same effect in humans? And this is now over 6 years ago. This is our first patient who we started with treatment with ruxolitinib. Here alopecia that was long-standing. She had over 20 years of almost complete hair loss was restored. She had Sjogren's syndrome as depicted by impaired salivary flow rate that was also restored. That woman had very severe autoimmune enteritis that also resolved clinically and histologically, and also had resolution of her gastritis, arthritis, and nail dystrophy. This is patient number 2, who, among other things, had 3 to 4 episodes of oral candidiasis every year, requiring about a month of fluconazole each time. Now, while on ruxolitinib, he did not have oral candidiasis recurrence. In this particular case, we were able to get serial oral biopsies from him just before and 2 times after starting ruxolitinib. You can see the increase in interferon gamma normalized and associated with not getting candida anymore. This is his stomach. So he had impressive chronic atrophic gastritis, where you can see the thinning of the gastric walls to the point that you can see the blood vessels restored to normal within a few months after treatment. And that's because all of this inflammation shown by H&E and the interferon gamma excess is ameliorated. This is a patient who had so severe diarrhea 12 times a day that at the age of 14 was weighing 29 kilos, doubled his weight over the course of a year. And this is actually a patient that we treated with Saila in Finland, who also had very severe autoimmune enteritis, was requiring TPN. You see this impressive inflammation with interferon gamma excess that resolved, and the patient went into clinical remission and remains on clinical remission to this date. Now, interestingly, as with mice that I showed you earlier, not only we can restore the readouts of gamma excess downstream of JAK inhibition, that is all of the CXCL9 phosphorestat 1 that I showed you, but also we can decrease the production of interferon gamma in these patients, so that upstream of JAK inhibition. So you see here PBMCs taken from a patient before ruxolitinib. If we give ruxolitinib in a test tube and then stimulate the TCR, interferon gamma decreases. And if we take this patient after ruxolitinib, that has an additional effect. This raises interesting questions with regards to what the intracellular half-life of ruxolitinib is, because in this setting, we add exogenous ruxolitinib here in a patient without even being treated in vivo with ruxolitinib. So this is an area where we're trying to gain further insight about how JAK inhibition causes that. Last but not least, we were, I would say, positively surprised to see some responses in endocrine manifestations that we didn't expect that we would see. On the left, you see a patient who had long-standing autoimmune thyroiditis. On a semi-regular basis, the patient would decide to stop his levothyroxine, and his TSH would go up, and he would not feel very good, and then he will start it again. After about a couple of months that he was on ruxolitinib and improved in many aspects of his disease, he on his own decided to stop levothyroxine. And now this is probably 4 years now, 4.5 years of levothyroxine. His TSH has remained normal, suggesting that his thyroid inflammation had not yet led to thyroid tissue fibrosis. That is, it was at the point that hadn't reached the point of beyond return, if you will. On the right, you see a woman who now has enrolled in our IRB-approved clinical trial, who had primary ovarian failure, an undetectable anti-Müllerian hormone that increased gradually over the course of time. And while she had no menstrual periods, over the course of the first year after starting ruxolitinib, she started having menses, again indicating that in certain settings when endocrine tissue reserve is still available, there might be an opportunity to reverse some of those manifestations that we don't think of them as classically being reversible. Now, over the course of these years now, we've treated either here or in collaboration with colleagues across the globe, 25 patients, all of whom have had life transformative clinical responses. And the summary of the manifestations that we've seen responses is listed here. So almost 20 different autoimmune manifestations. The ones that I have highlighted in blue are diseases that broadly in internal medicine, we don't really have good treatments for. This data would suggest that knowledge gained from a rare disease like APECED might actually have far more reaching implications for treating more common polygenic diseases. So we've started some work in that space. To give you an example, there is now deployment of a JAK inhibitor clinical trial here at NIH with our NIDCR colleagues for Sjogren's, idiopathic Sjogren's, that also features increased interferon signatures. And another thing that I'm going to make, since we're in an Endo-ERN webinar, I think the data that we've seen responses in some patients with thyroid, ovarian, hypoparathyroid, and pancreatic inflammation would also suggest that in some patients, polygenic, if you will, autoimmune endocrinopathies, even outside of APECED, might also be amenable to therapeutic intervention, especially early on, before tissue fibrosis ensues, in which case it's unlikely that this will happen. Now, all of these data have now led to deployment of a formal IRB-approved phase 2 clinical trial here at the NIH Clinical Center, where in addition to obviously doing this under the auspices of a formal trial, and which has its merits for a rare disease, we also have an opportunity to actually look at how JAK inhibition affects tissue-specific immune responses at the single cell and spatial resolution using site-seq and spatial transcriptomics. there are very important questions that have to do with, still what drives the activation, recruitment, and crosstalk and interferon gamma production of lymphocytes in situ. So these are very active areas of research in our lab. I alluded to earlier, we've now started already a program by which we take very early young kids that are about to develop irreversible manifestations and under very careful monitoring. Obviously, we've had some very early promising data with regards to being able to ameliorate otherwise irreversible in the future autoimmune manifestations. So this is something that I think I consider as the next frontier, moving from treatment to preemptive therapy, if you will. And last but not least, we've been in advanced discussions with Sobi that has the monoclonal antibody targeting interferon gamma called emapalumab. Now, this got FDA approved in 2018, so after we had started treating with ruxolitinib, the patients. But I think that's the area where we're about to initiate a formal IRB-approved clinical protocol targeting patients with emapalumab, if you will, a narrower modulator in contrast to JAK inhibition, which of course inhibits interferon gamma, but can also inhibit type 1 and type 3 interferons, IL-6 signaling, IL-12 and IL-22 and IL-23 signaling, growth hormone signaling, hematopoiesis through JAK2. So if we could show efficacy with emapalumab, I believe that in the long term, this might be a safer treatment modality from a standpoint of patients being on it for several decades. So to end, I'm going to just share some practical safety considerations and what we've seen with regards to safety. So we've decided to put everybody on valacyclovir. If you look at trials of JAK inhibition outside of APECED, up to 10-15% of patients can develop HSV and zoster infections. APECED patients do have a higher incidence of those infections associated with the fact that they have autoantibodies against type 1 interferons. So we made the decision to put everybody on valacyclovir to prevent those infections from happening. As instructed by the package insert, quantiferon positivity is important to rule out. If the patients have active opportunistic infections, they are not a good candidate for being on a JAK inhibitor. If they have a risk for hepatitis B, we've chosen to put them on entecavir prophylaxis to avoid the possibility, of reactivating hepatitis B and having fulminant hepatitis B. We've had actually a couple of patients that have safely received ruxolitinib in this context. An important thing that we've so far haven't seen reactivations with ruxolitinib specifically is BK and JC. There is a very low but not zero risk of BK nephritis or PML with JAK inhibition. There is actually a patient who was heavily pretreated in the past with things such as Campath and other immune modulators who reactivated BK and developed BK nephritis in the context of a non-ruxolitinib JAK inhibitor that is renally secreted. Ruxolitinib is not renally secreted, so I think it's important, even with ruxolitinib, where in the 20+ patients now we haven't seen BK reactivation, to keep in mind those two important preventable potential opportunistic infections. Bone marrow suppression is a risk for all JAK inhibitors. We haven't seen it in our cohort because the doses that we see responses are far lower than the maximal FDA-approved doses, and I think we have a therapeutic index, if you will, for that. And the other thing that is also important to keep in mind, broadly speaking, of JAK inhibitors, is there is a low but detectable risk of thrombosis, and also, as with all immunosuppressants, a good skin care with a high SPF sun blockers is critical, because squamous cell carcinomas are a risk for any immunosuppressive therapy, including JAK inhibition. So with that, I would like to thank the many people who've really contributed to this, from members past and present of my lab to collaborators across NIH and across the globe that have really helped us expand our data beyond the patients we've enrolled here to other patients in Europe and across the United States as well. With that, I would like to thank you for your attention, and I'll be more than happy to take any questions.
Thank you, Michalis. There is already one question in the chat, and I hope more will be coming. I will first, before I go to this question, I will ask one that is, I think, crucial. Is what would your advice be if there's an ill-faring APECED patient where we have, of course, no way of knowing whether the fibrosis of end organ damage has progressed too far to respond or not, and to the patient's doctor, whether they should attempt to JAK inhibition or not, and if so, would they be able to recruit these patients to some study of yours or some other study?
So you're referring to a patient who has no
Long-standing disease.
long-standing endocrinopathies without non-endocrine manifestations, or meaning do they also have lung or GI or alopecia, or it's exclusively, let's say, a patient who has long-standing adrenal insufficiency and hypoparathyroidism and nothing else?
I'd say that the lung and gut will, of course, kind of force you to start, I think, because that's the only way to control it. But then the others with, let's say, alopecia and annoyingly active CMC and all kinds of other umpteenth autoimmune manifestations along with those.
I would say the answer to most of those scenarios would be it would be important to consider it. I would say that a patient who, let's say, only has very mild CMC, one episode every 2-3 years, and only hypoparathyroidism and adrenal, let's say just a classic triad, and long-standing adrenal and hypoparathyroidism, I wouldn't probably prioritize that one, mostly because I think it would be unlikely when someone has 10 years of adrenal and parathyroid failure that those would be restored. But I would say the vast majority of patients wouldn't fall under that category. I think they would have non-endocrine manifestations that would make them good candidates to consider this. I would say one of the patients that recently was treated with a JAK inhibitor had to come off insulin because he became hypoglycemic on a JAK inhibitor after being on insulin for several years. So we're about to start a patient now, just to give you an example, who has GI disease that is difficult to control, but also type 1 diabetes with a C-peptide and an insulin level that is not undetectable. So they're at the low level normal. So that patient has probably beta cell reserve. And the question here would be whether he would respond. I would think that there is a good likelihood of it, but we don't know for sure. So a patient like that, I think, would be fair game to consider it. I think to your second question, we do have an open phase 2 trial here at NIH. It does have a few, over the course of a year, 5 inpatient or outpatient visits to the NIH. So it's a little bit difficult to travel back and forth outside of the United States or Canada or Mexico. If someone wanted, we will be more than happy to obviously enroll the patient. But what we've done in those situations is we've worked with colleagues, including Sila and others, where we are happy to share all of our SOPs. I think if we do it in a way that we've done it so far, which is a careful escalation of dosing, we do find in the individual patient the right dose that is, in most cases, far from toxicity levels. So we're more than happy to work with anybody in Europe to do it remotely so that everybody can benefit from this.
Right. Now to the question in the chat. Camilla, please comment first.
Thank you. If I can ask one quick question, and Mikko, you could then ask the question that's in the chat, which is very long. So my quick question, I'm an adult endocrinologist. So the APS1 patients that I see are not young. So I would like to ask you about the point of no return. Is there an upper age limit cutoff where it's too late to even try ruxolitinib I think about hypopara, type 1 diabetes. Would it be would you have any idea when to not mislead the patient,
Yes.
not promise too much? Thank you.
So we have treated patients in their 40s, but not because they had only adrenal or parathyroid deficiencies. They had alopecia, severe enteritis, gastritis, and other problems. I would say if the patients that have had those responses were mostly in their teens, that is, they didn't have long-standing endocrine failures, and it's not in all patients. So not everybody who has had ovarian insufficiency had an increase in AMH. I would say if someone is in their 40s and they've had long-standing adrenal or parathyroid failures, I think it would be extremely unlikely that there would be a response. And in those patients, we wouldn't put them on ruxolitinib because of the potential risks. It's relatively easy to, obviously, as you know better than I do, to measure intact PTH, or, if the ACTH steam test has a peak of cortisol of less than 1, or their C-peptide and their insulin are 0, I think that would be considered, what you said, a point beyond return. So we wouldn't, for those reasons, put the patients on a JAK inhibitor.
Thank you. Then the question in chat: autoantibodies against interferons in APECED are often considered neutralizing and a significant cause for severe forms of infection, such as COVID-19. If increased interferon gamma production is the cause of many target organ damage in APECED, what is its relation to the neutralizing antibodies? Could it be that the antibodies are not absolute in their neutralizing capacity, either because interferon gamma production overwhelms local antibody concentrations and/or that the antibodies do not penetrate these tissues enough for absolute neutralization, allowing the local damage to interferon gamma? On the other hand, can you speculate why interferon autoantibodies increase infection severity despite increased interferon gamma production being a driving mechanism for organ damage otherwise?
So great question. So I will start with the very latter, where we actually have some experimental data in mice. And mice don't have type 1 interferon autoantibodies. So I do think that so there is a higher risk of certain infections in APECED patients, and that likely maps to their autoantibodies against type 1 interferons. So COVID, especially in the early days, where the disease was a far more pathogenic virus, if you will, where a lot of patients, especially who had autoimmune pneumonitis, did get severe disease. So I think that's an example. I think about 10% of APECED patients do develop HSV and VZV. That probably maps to that. I think the fact that they have enhanced interferon gamma responses likely ameliorates some of the effects of type 1 interferon autoantibodies when it comes to viral disease. So if we take a mouse with APECED, they're actually hyper-resistant to viral disease. And if we neutralize interferon gamma, then they have more susceptibility to the disease. But it is of note that because interferon gamma obviously is important for viral control, I think that the data would suggest that the increase in interferon gamma that these patients might have might actually be a protective factor, despite the fact that they have type 1 interferon autoantibodies. To the point about the crosstalk between type 1 and type 2 interferons, there are different transcriptional programs that go for either or. So, I think we do see less type 1 interferon readouts in the tissues, and we see a prominent type 2 interferon gamma signature in the tissue. So I think whether the autoantibodies fully penetrate into tissues, I think that's an important question, and I think the answer is not. But we certainly see clear serum and blood inhibition of type 1 interferons and some amelioration of type 1 interferons in tissues. But that's not necessarily blocking interferon gamma, because the CXCL9, for example, is a type 2 interferon selective gene as opposed to CXCL10. So those two pathways don't necessarily overlap 100%, if it makes sense.
Thank you. There are 3 more questions. We have basically, in principle, we have 1 minute of time, but if it's okay with you, then it is okay for Amy, I know, that we will continue a little longer, and those who can stay for a little longer. Is it okay, Mihalis?
Absolutely, yes. No problem.
All right. Then, Tiina-Maija Tuomi, thanks for the elegant presentation. type 1 diabetes is not so common in APECED, but antibody positivity and decreased first phase insulin response to IV glucose is, presumably representing a subclinical process. As a side finding in the patients that you treat for other reasons, would you follow whether the insulin secretion recovers as a proxy for a decrease in the pancreatic inflammation? You kind of almost replied to that, but not fully. So
the answer is yes. So, the way actually our phase 2 clinical trial is designed is, it has a primary endpoint there of alopecia. That's how we designed the study back then. But it has then secondary and exploratory endpoints that look at every single autoimmune manifestation, including long-standing adrenal insufficiency. Again, the design of a trial is better, as you know, to predefine endpoints and not come back and, oops, we saw that as well, and now we change our minds and we want to look at that. So, to answer the question, we look at all endocrine tissues, even in patients who have long-standing autoimmune destruction. Now, I would say we have seen a couple of patients who didn't have frank type 1 diabetes, but they had impaired glucose tolerance. I wouldn't say that that's a common feature, at least in our cohort. And I don't think that we have treated any of those patients with a JAK inhibitor to be able to directly answer the question. But by the token of what I showed you earlier, I would say those would be patients that maybe they are on their road to develop frank diabetes, but yet have plenty of beta cell reserve that I would think that a JAK inhibitor would be potentially effective. That's where teplizumab, for example, has made the bigger difference, right? So, in the patients who are treated with anti-CD3, they are in glucose intolerance, they're not yet in frank diabetes, and that has been shown to delay the progression of the disease. So it's just we haven't yet directly tested that to be able to answer that question conclusively.
All right, there are still 3 more questions at least. The next one is actually the one that I was going to ask as well. Does Ruxo replace rituximab and azathioprine or Cellcept in pneumonitis?
Yeah, a great question. When we started doing this 6-7 years ago, and because we already at that time knew that azathioprine and rituximab has very, very good responses in liver and lung, we were reluctant to switch patients before we knew what ruxolitinib does. As of probably 2-3 years now, we've changed that approach. So, we now know that patients with autoimmune pneumonitis and autoimmune hepatitis respond very well to ruxolitinib. So I think the answer to that question would be a JAK inhibitor would make all tissues respond in addition to the ones that. So it would be a replacement, if you will, of azathioprine plus rituximab that only works for a subset of diseases. But we were cautious in the beginning to not jump into, replacing something we knew it was working. And also for hepatitis, this is a well-established standard of care outside of APECED. But I think now we have treated enough patients that had those manifestations that we feel comfortable with it. Yes.
Thank you. That was by Timmy Martelius, my right hand, by the way. Olle Kampe asks, what is the risk for teratogenic effects of ruxolitinib if used for autoimmune premature ovarian insufficiency?
Yeah, great question as always by Ola. So there are some data in mice treated with JAK inhibitors that JAK inhibition might lead to premature deliveries or miscarriages. As a result of that, there's been a warning from the FDA to use JAK inhibitors during pregnancy. We're actually discussing that with our clinical pharmacists as of recent, and we are actually asking the companies that make JAK inhibitors to release to us information that may have of inadvertently receiving JAK inhibition during pregnancy in a few women, as it happens many times. And we don't have that data yet. But as of now, if someone were to want to become pregnant, I think it would be important to not be on a JAK inhibitor at that time. So that's something that it's an important point. Whether the gamma monoclonal antibody would be the answer to that, rituximab is a safe option, and Ola has some data that it might work actually in ovarian failure outside of APECED and perhaps within APECED. But it is true that up to this point, out of precaution, it wouldn't be something that during the pregnancy that, or at least the beginnings of the pregnancy, that would be something that would be advised.
Okay, and next, Camilla.
Yeah, thank you so much. In a study published in 2015 on 31 Finnish patients with APS1, diarrhea was found in 45% of these patients and constipation in 48%. So we have a lot of patients with this. It's been confusing. What is this? I mean, what are these gastrointestinal problems? So what's your experience? How many of the patients, you've seen a lot of patients, how many of them have these gastrointestinal problems that would actually be treatable?
Yes. So I would say about 3 out of 4 patients with APECED do develop autoimmune enteritis. Some as severe as, having 15 bowel movements a day and having a BMI of 12 and being on TPN and completely malnourished. And some having milder, 2-3 loose bowel movements a day that they've learned to live their whole life with, which is not normal. And also, as you pointed out, some actually have the complete opposite. So, that very first woman that I mentioned that we treated had 1 bowel movement every 3 weeks, despite taking 14 laxatives every week. So, I would say all patients who we've treated so far have had severe GI disease, and all patients have responded. It's actually, it's hard to make that up. And actually, for a while, we was like, well, maybe the first 4, the first 5, the first 6. So this is a disease that does not respond to anything else reliably, and it appears to respond in all treated patients, and many of them actually with quite low doses, and very quickly, within a week of the right dose, patients have impressive responses. It has a very interesting pathogenesis that we've spent about a decade to try to understand, and I think we're close to be able to. What I can tell you here is interferon gamma has been known to be toxic to intestinal stem cells and the progeny, and we know from prior studies that we have confirmed in our group that many of these patients lack enteroendocrine and or PANET cells. And I think the central pathogenesis of the syndrome is excess interferon gamma is actually toxic to that pathway of stem cells differentiation to those cells. And when you give patients ruxolitinib, that gets restored. Actually, in the patient that we treated with SILA, who had no PANET and enteroendocrine cells, there was complete restoration of those cells after ruxolitinib. We see that in other patients as well. So I think it's a very common manifestation. In a significant amount of patients, it's actually a very severe, life-compromising entity. And actually, we've been extremely pleased to see that every patient so far has responded to it. And I think there is a basis for that at the pathogenesis level. We hope to have that published soon so that it's easy to follow, because it's a very complex underlying circuit that maps to that axis.
Yeah, it might be a bit complicated in Finland to get off-label use for ruxolitinib in APECED until more data is available and published. But thinking of Ulle's question on primary ovarian failure, would you start emapalumab? Of course, because in Europe, EMA has not approved emapalumab, so it can only be used as a part of a trial and not clinically. So, but have you tried yet for POF?
No, we have not tried the emapalumab yet. I mean, part of the reason is because this is an extremely expensive drug at the moment, and even if it's FDA approved, we cannot afford it outside of a context of a clinical trial. So, but we've had about 7-8 months worth of discussions with SOBI, and we're at the final stages of preparing a protocol with the primary endpoint actually there being GI disease, so that one is to not overlap with the ruxolitinib, but also because I think that's going to be one that very quickly will know whether emapalumab works the same way that ruxolitinib does. I would say in the mice, I'd say gamma excess drives about 90-95% of the ruxo effects. So you could discern a potential additional element of remission from ruxolitinib. That is, there's probably some gamma amplifiers, whether that there's IL-12 or other factors. So I think our approach is to give emapalumab to patients who have GI disease. And as you know, Miko, even here, many times with drugs, even with ruxolitinib, to get it approved off-label, it's many times a battle with funding or insurance or other agencies. But for the there is now our paper. There is a French paper that showed in 3 patients improvement. There are going to be other papers that soon, hopefully, from us and others, will have an excess of 20-30 patients showing an effect. And then for a rare disease like this, I think that could be an impetus to really go back to those agencies and push harder for that. I think at some point there's going to be our IRB approved clinical protocol published. I don't know whether that will take 2, 3, 4 years, because it's not very easy to recruit for a rare disease, even for us who have a lot of patients. But I think we all can work towards educating and pushing forward for and advocating for our patients, and that's part of it. I think it's not easier here. That's what I'm trying to say.
So still 2 more questions. I'm very happy with the amount of questions here. This is probably the longest chat after an ERN meeting I've ever attended. Nice to moderate it. Eva Ryhänen asks, first of all, she thanks you for your excellent and inspiring presentation. Patients will need ruxolitinib for the rest of their life. Can you see any risks in that, or can ruxo be used for a very long time? We kind of touched that already somewhat, but go ahead.
Any immunosuppression long-term has toxicities. And I think ruxolitinib is not an exception to that. I would say the longest treated patient that we have now is probably over 5 years. On Valtrex, as I mentioned earlier, actually that patient decided, he's the same patient who decided to stop levothyroxine. So, you see the pattern here. Decided at some point to stop Valtrex and actually got dermatotomal zoster. And then, now the patient is more convinced that valacyclovir is going to be useful. So I think the key here in our experience so far has been, if we take the FDA approved dose approval is 25 milligrams twice a day. And the doses that we've seen, the vast majority of patients having responses for APECED are between 10 and 15 milligrams twice a day. I think we have a drug that in this particular setting appears to work with doses that are lower than when toxicities mostly happen. Now, that said, I think it's important to continue surveil. So all of our patients, they get periodic labs from CBCs to make sure they don't get anemia. I think I mentioned some of the viral PCRs a couple of times a year, including BK and JC. They need to be surveilled for any opportunistic infections. So the fact that we haven't seen so far with ruxo monotherapy those devastating complications happen, that doesn't mean that if someone or 150 patients over the course of 50 years end up being on that for decades, that those are not risks. I think though that the benefit of the drug in a devastating disease like this, and also the careful way of doing it, should be able to ameliorate a lot of those. And again, many of them are preventable, meaning if someone, for example, has a BK PCR reactivation, stopping ruxolitinib will prevent developing of BK nephritis a year later if nobody tested. So I think that's the best answer I can give for now.
Thank you. Then there is at least one question left. Anna Nordström asks, are different doses required for effects in different organs or tissues?
Yes, great question. So I would say the one manifestation that appears to require higher doses, that is not though inconsistent with what's been shown for the dose of JAK inhibition for this manifestation even outside of APECED, is alopecia. So we do tend to need longer periods of times and sometimes higher doses, and many times even reaching 20 milligrams twice a day for a few months to get alopecia under control, as opposed to GI, candida, and other endocrinopathies, other non-endocrine manifestations, that typically respond to lower doses. So alopecia skin manifestations would be that potential extra dosing. Now, the good news about what our experience been so far is that when they respond to that higher dose and they have a response, we can decrease the dose to what I believe being safer levels without losing efficacy. So they might need a brief period of induction, but then they're able actually to be maintained on lower doses, which I think are safer.
And JAK inhibitors are used for dogs and dog skin problems. Have you thought of giving emollients with JAK inhibitors to even avoid that
So,
increase?
for patients who have alopecia areata, there is actually clinical trials with topical JAK inhibitors. I think there was a lot of enthusiasm when this initially started outside of APECED. Unfortunately, the clinical efficacy has been quite disappointing. The only group that there is a higher chance of response is very young kids. So kids less than 8-year-old, they're more likely to have topical JAK inhibitor responses. So, that would be something that could be potentially considered in an 8-year-old that has, maybe well-established endocrine manifestations and only alopecia. We have not had a patient like that to try it, but that would be something that is worth, I think, a trial. It's not like all of them respond. I think still the response rates are not quite impressive, but for adults, I think it does not work. And for young kids, this is probably something that's worth an early trial before going to a systemic JAK inhibitor.
All right. I see no more questions. We exceeded our time by 16 minutes, but it's only a measure of the excellent results that you have gained over 12 years now, and with very systematic studies. And I really warmly recommend anyone in the audience and everyone in the audience to read the New England Journal of Medicine article. It really is a treasure trove to those who are interested in treating these patients as well. Okay, and Michalis, again, warmest thanks for excellent presentation and for all the good work you've done. I think it will make a big difference for quite a few patients in the world.
Thank you so much, Miko. And anybody who has questions or wants advice about patients, please don't hesitate to reach out directly.
You can always raise your hand or you can type it. Right, there's just clapping.
Anybody could send an email at any point about any of their patients, so that we're happy to help and work together. Thank you all for inviting me.
Thank you for taking this time, and I think Europe will be wiser after this.
Bye.
Bye.